Jen, how's it going? Yes, it's going.
Yeah,
it's going great. We took our 2-week break for Thanksgiving. Kind of chilling out, resetting, kind of looking at where we want the podcast to go. Really did some thinking about it. Don't worry, guys. We're not going anywhere. We're still here. We're still working on this thing. This is a project. It's in progress.
Yeah.
We're learning ways. And of course, this being the first week of December, it's run review time. Yay!
It is. It is.
Run review. Yeah.
Hi, I'm Jennifer Schutz, and I'm the lead medic.
Hi, I'm James Schutz, and well, I'm the lead medic. And together, we're the Whiny Medics. So we got some really cool things to talk about for Run Review. We've had some really cool calls to discuss within our group of people that we work with. But for right now, first off, let's talk about my gorgeous, beautiful wife that come home with a present the other day. I let her go to Cedar Park all by herself. She was gone forever. Actually, I was at work and I got home and I'm working in the shop and she shows up and she brings me this really big can. That's whenever somebody says that they've had 2 beers, their cans these size. Yes, that's my hand. That's a grown man hand. And that can is, massive. Massive.
That's like deja vu. Like maybe we've done this already.
We did.
About 5 minutes ago when you stopped the video to tell me I had something in my teeth.
Yeah, well, yeah, but you'd have been mad if I'd have left the video keep going, but that's okay. We're just going to, I was going to act like it never happened, but no. So let's talk about the Thirsty Meal because we went down there and got some of their sparkling cranberry for Thanksgiving. We drank 2 bottles of that. That was amazing.
We killed 2 bottles.
We're going to have to get some more for Christmas. We discussed because of that. Okay. Mm-hmm. Did we catch back up to now?
I think so.
Okay.
So now, right. Not really, because he missed the whole part about how I told you about the glasses.
Oh yeah.
So the glasses we actually got probably about a year ago.
Mm-hmm. Yeah, it was about a year ago.
Went down the Dripping Springs and stopped at a tasting room that had beer.
Yes, they had tons of beers.
But they were featuring a Whitestone beer. Couldn't tell you what it was. Mm-mm. But if you ordered that, you got the 2 glasses with it. So now we have beer to drink with the glasses.
Yes.
So I went into Whitestone Brewery the other day. If you don't know where it is on Whitestone Boulevard.
It's on Whitestone Boulevard in Cedar Park, Texas.
It's kind of like, if you know where Wild West is, it's right in that
shopping
vicinity.
Center.
Yeah, it's behind the H-E-B.
There's a cigar shop that's sitting right there beside it close too.
Mm-hmm. And a karaoke bar and a pool billiards bar.
Yeah, a really cool little area that whole part of Cedar Park has really grown up as a pretty cool little area to chill out.
But you can go in and it's really laid back. I guess there's probably seating inside for about 30, 40 people maybe.
Oh, yeah, at least.
And walk up there. They have all their beer and what it is. They're very kind and helpful. They'll tell you what everything is. There's seating outside. You can take your dog. There's a taco truck. Had great food. So me, David, and James went down there one night after I bought the beer.
Yeah, I've got 2 other different types of beers at the house, but this is the one. This is your favorite. This is the one she chose.
Okay. So when I went there, I bought one that was called the Melting Snowman.
The Melted Snowman, which was very good.
Hints of nutmeg and cinnamon in it. Very good. And it's a dark, they don't do ales.
Right.
But it is a darker beer. So, and then I got James one.
Yeah.
And we haven't tried those yet. They're still in the refrigerator.
No, one is the Melted Snowman and one is it's the Keyboard Gangster.
You hadn't opened it yet.
No, I have not opened the Keyboard Gangster.
So we went to Whitestone and I chose this beer that we're going to have today. And he tried the keyboard gangsta.
Yeah, keyboard gangster.
So then I had to break it to him and tell him that's one of the ones we had at the house, and he wasn't very happy with me because that good beer's been
It's
sitting.
been at the house for a week, and I didn't even know it. I could have drank. Whoa, what are you doing?
I don't pour beer. You pour beer.
Oh my God, she's like gonna foam this all up. You can't do that.
I'm so much better at pouring wine.
Yes, you are. You got
this is
very
the
little head on that thing. You gotta get
rated
it right.
R beer. It is 10% by volume alcohol. I know I'm saying that wrong, but it's potent. So
It is a potent beer.
Yeah, that's enough. Why are you giving me more?
Oh, because okay, don't worry, I'll drink what's left. I'm not worried about that. It seems like it's gotten a little flat for us, though. It'll be all right.
So, if we get the video up, you can see it's a little bit darker, but it is one of their beers. I don't know which one it is, but they poured the beer in different barrels of bourbon, whiskey barrels, rum barrels, and let them age. And then they poured them all together and came up with the rated R beer. So they will never produce this particular taste again. Yeah. They can do the whole process again, but it more than likely will never taste the same.
This will be the second one that I've had that has actually been a beer that's been aged, and it's a stout that's been aged in a bourbon or a rum barrel. I had one at BJ's Brewhouse the other night that was really good. And this, I want to say, I don't know how new of an idea this is, but you talk about changing the flavor of some beer. It's amazing the way they change the flavor of a beer. I'm not normally a dark beer drinker. I like the lighter ales, ambers, things like that, and IPAs, but not the dark stouts. This one, it's potent beers for sure.
Well, and they were serious about it because they gave them nice big glasses of beer, and I had this little bitty one.
Oh yeah, it was so. But yeah, it's got a really different flavor to it, really different smell, completely different smell than you've normally had.
Like a whiskey or a rum, maybe smell to it. I don't know. I don't know how to describe it.
It's different.
You gonna leave some for later?
There ain't nothing better than getting it in your stash and you can taste it later. I'm just saying, that's why they make these mustache. The flavor savors.
So to me, it doesn't have the bitterness of a beer taste. It kind of changes. Once you get in your mouth, it just kind of changes that taste, and has a really great flavor.
It does.
I almost want to describe it as like a coffee flavor, but it's not a coffee flavor. I don't know.
I wouldn't say coffee, but the of course the bourbon and the flavors they're infused in it are way different.
Yeah, but anyway, I don't know.
Beer.
I don't know that beer will be. Yeah, we probably shouldn't drink that much of it.
Well, once you open a can, you might as well finish it. There's no point in playing with it. That is 25.4 ounce growler, the growler that's there. So we just split that. So that's only like a 12 ounce beer piece. It's good. 2 12 ounces.
Okay. So if you go to Whitestone Brewery looking for the rated R, it may not be there because they may be out of it.
Right.
But they have great beer. They're very knowledgeable in what they have and what's in it and how it tastes and what you might like. So go see those guys. And
the Melted Snowman is very good too.
Like 9, 10, or 11 types of beer there.
Yeah, they've got several of them and some island lagers
up there
that are really nice. The environment there is pretty cool
laid
too.
Back.
Very
laid back.
We sit out there on the patio and realized next time that we would make sure we bring the new pup with us and kind of let her socialize with everybody, as well as multiple people were there that he did have theirs.
I think she's socializing right now
with that Bella. Her and Bella are having fun. It's good to have 2 dogs back in the house again. So run review. Let's get on with this and let's get this done.
Yeah, because Mama got to go to bed.
Yeah, Mama's got to go to work. We done made look. We're recording this evening after making a trip to Corpus Christi and back. We had to make I had a business run. I had to make real quick. The firefighters, paramedics down in Corpus Christi did so. We're doing some not Whitey Medics with CE Solutions. Actually, is trying to keep their business for the next couple of years. But super chill people down there. We had to go down there and take care of some things and drop off some information to them. So other than that, that's about it. It's a cool day, cool into a day. Let's finish with our awesome podcast. So you tell me about this call. It's kind of interesting that I get this, hey, check this out. I sent you a picture call. And I was like, okay, what the heck? Mm-hmm. Go ahead.
Okay, so we don't actually have a report on this, so I'm just going to give you some information. So, 30-ish-year-old male, complaint of just not feeling well, missed dialysis, wants not an ambulance. Mm-hmm. You get on scene.
We all know those calls. They happen all the time.
Mm-hmm. Mm-hmm. You happen to be familiar with this patient. He has not been to dialysis for 8 days. A whole load of health issues, but diabetic, neuropathy. Oh gosh, I don't even know. Prone to infections. He's a sick person. Not compliant with medications, no allergies to medications, just hasn't felt good. And he'd been sick recently, and didn't feel like he should go to dialysis. So, you get him in the truck and, hook him up to the heart monitor, and you get vitals. So your vitals are, yep. Mm-hmm. Okay. GCS of 15, ANO times 4, but fatigued, significant facial swelling. Blood pressures were 180s, 150s. It didn't really give me a diastolic, but wasn't anything too crazy, they said. SpO2 is high 90s. Heart rate's anywhere from 70 to 170. He's a little more lethargic than normal. Can answer all your questions, but just seems tired. So... Does
he out and out say, hey, I haven't had my dialysis in like a couple days?
He's very honest and says, I hadn't done my dialysis. So I get this call. He says, I think I need a bird. I said, okay, what's going on? And she says, well, his forelead is his rhythm is very shark finish.
Shark finish.
Oh, wait, hang on. Shark finish. Yes, finish.
Shark
like fin.
Finish. Like a fin of a shark.
Ish.
Yeah. I would say if you had like capnography or something like that, I would use shark fin. If you're using shark fin as a way of describing a cardiac rhythm, stuff just went bad.
Well, honestly, the first thing I thought of was flutter.
Yeah. Because little bitty shark fins in between, in between QRS.
All right. I was like, oh, okay. Well, interesting. And we talked about it for a few minutes, and heart rate of the rhythm she sent me was 163. I see why she says shark finish, but it is definitely not a flutter. So, we'll try to show you a picture if we get video up. I keep saying that.
I'll put this will be in the on the YouTube video if y'all want to see it. Mm-hmm. I'll add it in here at this section to where you'll be able to see exactly what the cardiac monitor looked like for us.
But if you look at the cardiac enough and know a little bit about this particular rhythm, you know what it is. And this patient has very, very peaked T waves.
Peaked T waves. Dialysis patient, hadn't had dialysis in a while. Peak T waves. Mm-hmm. And I'm going to stop you for a whole second because we have this ongoing thing with my department where we have for years, when we do protocol tests, there is a 12 lead that we all know. and it's the peak T waves. And for some reason, that one always tends to find me when I got to do my cardiac, and when I got to deal with my the skills section of my protocol test, and I always get it wrong every single time. Single time, I don't understand. It blows my mind that I miss it, and it's funny because there's certain people who are going to listen to this podcast, and they're going to look at me and be like, "Yeah, we know. We were there. We watched you blow it right out the water and do everything great all the way up until the 12 lead come out, and you couldn't find the peaked T waves." I know. I mean, and treating peak T waves and everything else. The bad thing is that this is when you do a protocol test, you know where this is going. It's going to end up in cardiac arrest somewhere or another, and I've always missed it.
So let's just get one thing straight, and let's agree to disagree or whatever. But whatever she did in the back of that ambulance was not going to fix what was going on with this guy.
Not when it comes to hyperkalemia. Yeah. There's a lot of treatments we can do in the back that we can start. But this guy, ultimately, what does he need?
He needs dialysis.
He needs dialysis. He needs a dialysis center. And he needs some place that will dialysis. We'll put him through dialysis while he's there in the ER, or, move him up to the Florida where they can run him through dialysis.
And not every hospital does dialysis. No, and I think that's something that wherever you're at, you need to make sure you know.
I think that's one thing we need to look at is making sure we know what's in our area and what our capabilities are. If you have a lot of hospitals in your area, make sure you know the capabilities when it comes to important crap like that, like hyperbarics chambers. I mean, not every hospital has a hyperbarics chamber. Know the ones that do. Obstetrics. Not every hospital wants to deal with babies.
Oh, you will make your name will be mud for the rest of your life if you take a labor and delivery patient to a hospital that doesn't do it.
So make sure that you have the ability to know what's there. This patient needs dialysis.
He does.
We can start treatments on our way to the hospital. And we've got to, first of all, I think our first thing is we have to remember to stay calm.
Yes.
This is not a call that we see all the time, but when we do need to realize that it's time to get them to the hospital quickly.
We discussed this. Rhythm, because she wanted to. She was looking up her wide. She did the right thing. She pulled the protocol book out and looked at her wide complex tachycardia protocol. Okay. And she's like, well, amiodarone. I was like, yeah, this is not.
It's not a wide complex tachycardia.
Well, it is not a cardiac issue.
It's an electrolyte issue.
So we had a small discussion. I wanted to refer to the protocols and kind of check myself. So I told her to get going down the road. She chose to go to a ER, and you have to edit that out. And
can't do that out of the video. You're stuck. You shouldn't have said it. It's okay, but it went to a local hospital.
Yes. So, and she started looking for an IV. I checked out our protocols. And I did discuss it with another one of our medics who works elsewhere under the same doctor. So
she phoned a medic.
I did.
Our medic is amazing.
So, well, you have medics that work in different areas that have a broader protocols. Call volume and protocols than what we do, right?
Not only that, but it's always good to get a hold of medics who may have experience doing some of these calls that normally we may not have.
Well, and on top of that, this is a medic that I went on a hyperkalemic patient with. Okay. And I know her, and I know that she was going to study up on that.
Right.
So I looked up our protocol. Our protocol was, just in case you are wondering how to treat hyperkalemia in our ambulances, was to push 1 to 2 if you suspect hyperkalemia, and this was under our wide complex tachycardia. So if any of my crew are listening, you might want to look at your protocol book, to give 1 to 2 grams sodium Gluconate.
Gluconate.
Slow IV push. So my
really slow.
Yeah.
You want to be careful with any of these electrolytes, especially when it comes to giving these patients. If you slam something to them, there's a higher risk of putting them into cardiac arrest doing that. Then take your time on these.
Well, anytime I'm giving something more than, you just really, I think of any medication like I do D50, make sure your IV is good. So we discussed it, and she actually told me, and I found this interesting, that you start an albuterol treatment.
Yes.
On this patient.
It helps to move some of the electrolytes around.
Yeah.
If it's part of your protocols, of course. We work on different protocols because we're in rural settings. So there's a lot more medicine that maybe inner city doesn't have that ability to see that, hey, we can do all these things on the way to the hospital. Their primary focus is, 4 or 5 minutes to hospital. We're going to get you there and you're not.
Well, we have 20 to 30 to an hour.
Yeah, 20, 30, maybe even call in a helicopter because of the fact that we have so long before we're able to do anything, I think. But yeah, albuterol is one of those ones that some of its properties that are not just for the opening of the airway is to help move some of those electrolytes around and helps with hyperkalemic patients.
So she suggested 5 milligrams of albuterol. And then once you got your IV, the calcium gluconate, 1 gram, a slow IV push. And then you really, anytime you're going to push this next drug with calcium gluconate, you really want to flush it really well.
Make sure that you have that IV patent and clear.
Yeah.
Run some fluids through it for a few seconds. Let that run through and make sure there's nothing in the way before you push it. Go ahead.
So the next drug would be sodium bicarb, 1 milliequivalent per kilogram.
So what happens when you push them right behind one another?
Oh, I'm not the technical person you are. You go ahead.
If I believe right, that is the mixture that as soon as you push them together, they crystallize inside the veins. If I believe right, I don't know. Don't hold me to it. But if I remember right, something like that, they crystallize inside the veins.
It's fluid overload too.
Yeah. So it's a huge difference there. I mean, you don't want to, anytime we push a drug and we're going to push a second drug right behind it, flush the line. You only want one drug going in this system at a time.
I remember when I was working in a medical clinic, there was only 2 drugs that they would let you even mix together. And it was Phenergan and something else.
I was about to say Phenergan and morphine because those two
because it was for headaches.
Yeah.
So
wait a minute, you gave Phenergan and morphine for headaches?
Yeah.
I'm in. I got a headache right now.
So it was migraines actually. So anyway, so unfortunately, this person is very difficult to get an IV on, so that was not an option that night.
Which most diabetic patients that are on dialysis and have ongoing history are difficult sticks no matter what.
Yep. So this medic did the best that she could and kept him calm and kept her calm. And the one thing I did, remind her, and she's a very good medic. If she listens to this, you did great. But remember, even though this cardiac rhythm is important, to always watch your patient. Don't treat your equipment, treat your patient.
I don't know how many times Miss Cindy she has always told us, treat your patient, not your equipment. Treat your patient, not your monitor.
Now, she did realize that this patient was not his normal. He was more lethargic. His oxygen sats were low. His BP wasn't terrible compared to normal, but this was it could be a lethal rhythm. And me and Brandy found that out the hard way.
Yeah, I mean, if you prolong and leave this the acute hyperkalemic patient, if they continue, that electrolyte imbalance will create the abnormal rhythms, which will eventually lead to VFib, VTAC, and those bad things that are lethal. And granted, it makes your call a little easier because you know exactly what to do then.
Yep.
But it doesn't make it better for our patients.
No, it doesn't. And so we need to remember a lot of things when we go into these type of calls, because every time I've been on this call, it's been a diabetic that missed dialysis. So, one, you have options on your IV, right? You know, you have your IV, you have your IO, you have an EJ.
Now, do you go in the humeral head or you go in the leg?
Well, you would more than likely go in the humeral head because what do we know about diabetics?
Well, diabetics, they don't really have really good circulation down there in their legs, but you put it up there in that arm and it's guaranteed to drop in. I think that's the first time I've got you to agree with that.
Unfortunately, yes.
I mean, that's a whole nother podcast.
It is.
But,
it is.
Yeah.
And there was other issues that we won't put in here because I just don't think we need to. But there was another reason why we couldn't with him.
Right.
So
and normally when you have a diabetic, and a lot of times they don't heal as well.
No, they don't.
That's probably the biggest key is you're fixing to drill into their bone.
So if they have a
port,
or if they're diabetic, they have neuropathy. If you've ran on them enough to know that they're sick a lot, they have infections a lot, it may not be the best idea if they're stable to do that IO.
Yeah. You just really got to realize how bad they are.
Because this patient he could turn at any moment. But I don't know that I would have, and she chose not to do an IO in him.
Your next step is that EJ.
Yeah.
The all dreaded, the EJ.
And it is scary to think you're going to push calcium gluconate and sodium bicarb through an EJ. To me, that's a little nerve-wracking.
Yes. But see, that's the thing. That's what separates some of this. You bring up starting an EJ to some medics and they're like, you want me to do what? Yeah. You want me to turn their head this way and put it in there? You want right there? Can I try somewhere else first? And then you get other medics who are like, oh man, I start an EJ. I throw 2 EJs at the same time. Just like, be done,
That's the last resort for me.
It is. I've only started 1 EJ in my entire career, and that was on a cardiac arrest because I couldn't get anything else. And at that point in time, we didn't have Easy IO. We had the Jamsheedies. If anybody remembers the Jamsheedies, you didn't want to use those.
The Jamsheedy?
Man, you didn't want to use those on an adult patient that was obese because you weren't getting nowhere with them. They weren't no good at all. So you just better off shoving. And this was back in the day when we could put things down the ET tube, and that's eventually the route we took.
Was it you guys that the Easy IO died on?
Yes, and it was on my call that the Easy IO died, and there's a technique. Well, you sit there and start spinning the IO.
So one of the things that I learned in that cadaver class that I went to, because that guy was like one of the founders of the Easy IO, is that you could very easily use that as a Jamsheedy as well and push it through.
Man, that's so.
And I don't know if I would have thought of doing that, honestly.
That's caveman-ish. I'm just like, you want to push something through somebody's bone. That is the only time as a paramedic, you got to think that is prehistoric. We're just pushing things in the bones.
Just give me a hammer. Well, anyway, so I think she did the right thing. We discussed the helicopter and the fact that she would be waiting 20 minutes for a helicopter. She could already be at Marble Falls, which is not the best case scenario for the patient because of what he needs. But at this point, we need to get him somewhere where he can get stable. And so that's what she did. And she was probably cussing me the whole time. And she got him there and got him into the ER. And they were, she said when she left, they were trying to get IVs on him. So I don't have what happened to this guy. I don't have a result. But we all know that if things went well, that he ended up getting transferred to a facility that can do emergency dialysis, and he'll probably be in the hospital for a couple of days.
Yeah.
So my takeaway for that is she did great. She stayed calm. She kept the patient calm and talked to him. One thing she is great about doing is talking to her patients and,
Keeping
I
them
think,
calm.
yeah. And so she did a great job there.
She's good at.
She was frustrated with not getting the IV, and I had to remind her that we don't always get them.
Right.
And no matter how good you are at it, it depends on the patient. It depends on the day and what's going on with the patient, how hydrated they are, how sick they are. And it just, I knew going in that more than likely she wasn't going to get it.
Yeah. Well, okay. So let's take a quick break. Well, we've got a chance real quick. Let's take a quick break. We're going to come back. And when we come back, let's discuss dealing and what are some other things we can do besides just the patient care, getting them to the hospital, to maybe to help that patient that we transfer, that we deal with all the time. Mm-hmm. And maybe some things we can look forward to when we know we're going to that house.
Yeah.
Hey guys, James here. Are you looking to recertify your NREMT? CE Solutions NREMT program is an all-inclusive and will give you all the course required by the NREMT for recertification. Whether you're an EMR, an EMT, an advanced EMT, or a paramedic, CE Solutions has a package for you. Visit www.ems-ce.com for more details.
Feel better now?
I feel a lot better. All right, so we're back. Why?
Okay, so
why do you seem so thrilled?
Long day, long drive, long drive.
Oh, it's okay.
Okay, so let's talk about things that we could do to maybe prepare ourselves for this kind of situation, or enable the patient to take care of themselves.
Well, that's one thing we all have. We all have the frequent flyers. And I think we've talked about it on the Money Medics multiple times, how to deal with it, this and that, how to handle it with the new guy, how to handle it with the old guy. How do we handle it with a patient? At one point in time, we had a patient that, and I say this without violating HIPAA, that literally in a 6-month time period, everybody who works with me, who listens to this, is going to know exactly who I'm talking about. In a 6-month time period, called almost 800 times. It was up to 6 and 7 times a day that we were at this house, and how do you prepare for that? This location where this guy's at, where this patient's at, you're going to their house. You kind of know what you're walking into.
And you kind of get, I've heard so many people say this, that they get comfortable with
complacent.
And complacent, because they know what, it's this person, this is what they want, this is what's happening. And
I can't wait till I get old, because that's going to be me.
And then inevitably one day you walk in
and it's not what you thought it was. They're not sitting there talking to you. Now you've got, you've walked in there with your stretcher ready to load them up and take them to the hospital, left all your equipment in the truck because, this is Joe Blow, Joe Blow that we run on every day, that we deal with. And now we've got a whole different issue that now we're having to handle.
Yeah.
So
don't be that guy.
Don't be complacent and get yourself stuck with everything out in the truck waiting, is sitting out there. It doesn't work that way.
So
what are some things we can do? Do we take the time as paramedics to stop by early and maybe?
We used to do home visits in Llano, and people kind of balked at that, but I felt like when we did them, it prevented some of these people from calling us as much as they did. And some of them are just lonely, right? Mm-hmm. And then some of them truly just don't know how to take care of themselves. And so I've learned a couple of new things here recently. But one thing that I've always done, and my best friend happens to do it too, and just did it recently, and they were talking about it, is, with this dreaded COVID, people are not getting some of the services that they would normally get.
Yeah, they kind of cut out some of the meals. Was it the Meals for Wheels for Meals, Meals on Wheels, and things like that.
And so she went into a home not too long ago, and these people in a 2-day period had called 4 or 5 times. She cooked their meal for them. which is kind of funny because she doesn't cook.
Which is really funny because she doesn't cook.
Everybody's like, what are you doing? And I was like, what do you mean? We do it all the time. Don't you? No. Oh, well, I'm there to help them, but their medical needs, but I can't in good faith leave a home knowing that someone has, no way to cook their food, that no nutrition in their bodies,
I don't think that's going above and beyond our call of duty. Spending time and taking care of our patients in house. We've talked about it multiple times, this community paramedic type situation. And we've got a really good friend that we're going to have on in the show at some point in time, who just recently had a huge write-up done about being a community paramedic and somebody who was able to evaluate a patient, take care of some of their healthcare needs and things like that in home and never get them to the hospital. I think there's times when, as paramedics, us making a meal, us taking the time out of our busy schedule just shortly to move furniture around, as you said that you had done already, things like that. I think that makes us better people. I think that brings apart, I think it brings what paramedics do and what we do in EMS of being the guy that's, dealing with dragging people out of the cars and, doing all the things, the gory things that we've had to deal with. I think it brings us back to reality and says, hey, there are good things that we do as paramedics that are the nice things.
Well, just as much as you like to get out and run the cardiac arrests, the wrecks, the fires, the stuff that some of these guys actually like running. Maybe I did when I was younger. Yeah, I don't know.
Once you do this for a little while, you kind of those things kind of they subside. I like my bed at 3
a.m. But these people that are living alone that can't get out of their homes right now, they need us just as much. So
probably more than ever because of the fact that they can't get out of their house.
Spending that extra 5 minutes or 10 minutes or 20 minutes. Yeah, I mean, at some point your medical director may say, what are you doing spending 40 minutes on scene? But take care of your patient. Don't just leave them there. I have been on so many patients here recently that are not mobile. I mean, Cheyenne and I the other night went on a patient who literally can't get in her bed because of something that just recently happened with her. And we helped her, but we also, made sure someone was there with her for that night because we were concerned. But we also gave her ideas of, okay, let's think about, this is a really tall bed, maybe taking the bed frame out and putting the mattress on the floor where it's lower to the ground. And she was like, well, I was thinking about the sleep number bed. And Cheyenne came up with, and if anyone needs to know this, Cheyenne came up with this great information that you can actually go to Mattress Firm and get the base frame that moves like that and get a cheaper mattress and not pay for the sleep number, which was awesome. Yeah. So, we do a lot of lift assists. We work in an area that is populated with a lot of geriatric patients. So we do a lot of lift assists, and although I hate that they fall, I love those calls. I love being able to go in there and help them and them, being able to, feel better about the fact that they have someone that can come and help them and
I think
they can live at home.
Yeah. I think it's a matter of not every patient that we come encounter with that needs to go to the ER. Sometimes they just need a paramedic.
Now, if my medical director's listening to this, he's going to say, it's easier to write a call of when you take them to the ER than it is to write a refusal. You better document that too.
Well, and I agree with that. But at the same point in time, there's some patients, there's no reason to muddle up our ERs with some of these patients that
COVID,
basically can be treated well.
Right? With COVID, we have a resource guide that we give people so that they can stay at home if they fit the criteria to stay at home.
And here we are in November, December area. And our ERs and the ICU beds here in Central Texas have already started decreasing again. So second wave of COVID's coming through and our numbers are all up and everybody just like we expected. Now, COVID, flu, things like that. I think they're saying the flu numbers are actually down because of the COVID is kind of, but I mean, it's what have you. But I see, ultimately there's patients that just, I mean, if they fall and need help up, then that's what we're there for.
Yeah.
Don't go with an attitude and be like, now I got to pick you up off the ground again.
I got to write a report.
Yeah, I got to write a report of this. Help them up and get them up to where they go.
When they write a no patient report after they pick someone up off the ground.
No.
Yeah.
Liabilities in the, I will say this one thing. We have, he's probably more of the protective deputy chief that I've ever had dealt with. And he was protective of the department as well as of ourselves. And he knows who I'm talking about. I literally wrote patient refusals on 54 students in a school bus one day. Yeah. 54 individual refusals because I wanted to CYA. But if you write a no patient contact and you pick them up, what happens whenever they call back 2 weeks later and they've got a fracture because you didn't bother to check them out well enough? Mm-hmm. And that happens in the nursing home all the time.
Well, what happened to, I think it was me and Raylene, went to a gentleman's house, picked him up. This has been several years back. And he had bled. Mm-hmm. And I tried to get him to go. And he wouldn't go. And the wife and the son that were there were like, no, he's fine. And I was like, we could take him in. He's older, blood, head, swelling. They're like, no, just leave him there. He's fine. Just get him up in bed. So we did. They said, we'll watch him. He'll be fine. And so I documented a lot. Mm. And that next day, around 10 or so, the medic that relieved me called me and said, did you run on this guy and leave him in his bed? I was like, yeah. This is what happened. She's like, oh, well, they called us right after y'all left, and he was, unconscious and not really responding right. And, I was like, man, I felt bad. I felt awful. I left that guy there.
Yeah.
But I explained to not just the patient, the wife, the son, and no one would give me permission to take that gentleman out of there.
Wow.
And he was alert and conscious at the time. He was A&R times 4. He could answer all the questions, but he ended up being okay. Thank goodness.
What you have to do there is make sure you're documenting the heck out of whatever else you're doing.
You don't want to lose your patch over stupidity.
No, it's not worth it.
You can't make every patient go. And they know that. The doctors know that. The lawyers know that. Everybody knows that. But don't put yourself in that position. Mm-hmm. Do what's right. Don't cut corners. But that's not even why we're here. So let's talk about this patient. I think, and I've learned a couple of new things here recently. So one, let's educate the patient. So I learned when I started doing DAMSEL that I was already an educator, not only because I taught CPR, but when we go to people's houses,
we talk to them about what's...
Yeah, especially like diabetics. Mm-hmm. So we're already educators, right? All of us, every single one of us. EMTs, paramedics, doesn't matter. We're educators. So let's educate this patient. It's very important that you go to this dialysis. If you don't feel good and you have to miss that one day, get in the next day.
Yeah.
Or get in, if you're a Monday, Wednesday, Friday guy, you
may have to reschedule your Thursday and then cut it, or at least maintain and watch what you're doing on that missed day.
Keep your doctors informed of what's going on. Take your medications. Do you need a pill box? Do we need to get you something? Get the family involved. Talk to them. Ask them if you could talk to the family, and make sure that the family is involved and making sure that they're taking care of themselves. If it's bad. If it's bad, maybe APS needs to be called.
Well, not only APS, but I think this is where, as paramedics, we're not salesmen, but we're not actually, and we're not for sure not pulling one place or another. But I think this is where we start making contact with those outside resources that we have, home health networks, things like that.
So I recently
pulling those guys in.
Found out that there's a home health agency that's trying to work with a different EMS agency that way. Mm-hmm. And they're working together with it. And it's, they touch base once a week and give, they talk to their patients. They say, this is what, I would like to give your information to this person. This is home health. They can help you. Is that okay? They get permission. And I'm sure they've gone through their upper management to make sure it's okay. Don't just do that.
Yeah. You don't want to violate HIPAA no matter what you're doing. But at the same point in time,
as a whole department, they agree that this is a good thing. Then you get with them and say,
I think ultimately what this is a continuation of patient care. Yeah. This is when APS is so super inundated with child calls and adult calls, and they have all the true neglect stuff. I think home health steps in and they do a heck of a job.
If it's something like they forget to take their medicine, or they're not good at taking their medicine, or
they need a meal made or something like that.
They don't know how to take care of themselves. Yeah, get home health in there. They go in there once, twice. I don't know how often they go in, but they go in. Wound cares, physical therapies. I know one has a mobile radiology group that they use. So use that. If that's as a department, that's something that they decide to do, then once a week that referral goes into that rep or that nurse with home health, and then they evaluate to see if the patient is eligible. Why not? One, it's helping the patient. And you're not going to have that ugly call one day. Two, it lowers how much they call you.
Because now they have somebody that's coming in, taking care of them and helping them where they need to be. Not only that, for just the lonely patients, those that are lonely and they want somebody to talk to, this gives
Visiting
them
Angels.
Somebody. Oh, man. My mom works for Visiting Angels, and she enjoys it, and she works for a couple, I think she's down to one patient now that she is an advocate for this guy. And when it comes to everything, she tells him, sir, this is what you're doing and this is what you shouldn't be doing, because they shouldn't be allowing you to do this. And she's a huge advocate for that guy, for her patient, that she really, truly, these people who work for Visiting Angels, these people who work for home health, a lot of times they really have a drive to want to help the elderly. And I think it's sometimes as paramedics, it's time to call in for the relief and get somebody in there that's able to do the job.
A lot of us are in this for a reason. A lot of us have, it's just like my damsel in defense stuff. I personally didn't have, any kind of experience, but a lot of the women that sell that stuff is because they were a victim at some point.
Yes.
So a lot of us that do EMS or, fire, there's a reason we got into it. And so we need to remember that reason. That should be, it's just like your cohort that wrote the blood sugar on the wall to remind them. There should be something somewhere that reminds you why you're doing this.
Why?
It wasn't just for the paycheck. It wasn't just for the shift work so you have 4 days off. It was because you wanted to help somebody and make a difference in someone's lives. And that's something we need to remember. And with COVID, and I know everybody's tired of it, some people don't believe in it, and that's fine. But
it's a sickness, and I promise you,
our
when you
world
run
is
the
changing.
patients, when you hit the patients who got it and they're bad with it, the only time I can say that I've seen a patient that I knew had COVID, she tested positive for COVID. She had the look of, I'm fixing to die if you don't help me. And that scared me enough to where I know. They say they're positive for COVID. They're getting a full work. It's getting happening.
Yeah. So just remember those reasons you're in this, and remember that it's for the patient. And so if we're running on them 2 or 3 times a week, I don't mind doing it. And I want to help them, but maybe what we're doing is not enough if they're still having to call us that much. Yeah. So let's look at what else could happen. I have actually asked a patient while I was at the house, can we call your doctor? Yes, absolutely. So we called the doctor. She gave them permission to talk to me because she couldn't get through to them what she was trying to say. So I helped her, and she got in for an appointment, and life was good. But
that's being the patient advocate that we are all taught at an EMT level and up, is to be the patient advocate. The basis of all EMS should be, no matter what, patient advocate.
Yeah. So let's get these guys that have to have dialysis. Let's teach them to be better patients and go and do what they need to do, and remind them. I hate to say this, but sometimes we have to remind them that what they're doing is not just affecting them; it's affecting that family member that's there with them.
Not only that, but they need to be reminded of what the outcome can be if they don't continue taking care of themselves. Every now and then, letting them know, this very well could have led to us in a completely different circumstance.
No.
Us pushing down on your chest, trying to get you to live. And
Which, let's
you
face
being
it,
dead.
that patient will not heal from that very well at all.
Well, no. And unfortunately, the call that we're running here very well could have ran into cardiac arrest, and he's got family, he's got loved ones, and I'm sure they wouldn't have enjoyed the fact of us coming in and having to do all this, for the potential for him not to make it because he missed his dialysis. That's the hard part is we've got to remember to be patient advocates. We've got to remember that education should be one of our high points for these patients. Getting irritated with them because we have to write another report. Look, if you don't like writing reports, find another job. There's a lot of other jobs in EMS that doesn't require report writing, that doesn't require patient care, and you can find some of those to do.
I think McDonald's is hiring.
Yeah, I think so. But at least that way you don't worry about putting somebody's life at risk for something it shouldn't be. But, that's part of what we do.
Resources. So home health, visiting angels, carts.
Yes. Trying to find ways to get these people back forth. The vet rides.
There is another medical.
There's a lot of medical transports that they can find ways to. I think making sure we make contact with the family and getting the family involved is
with the patient's permission.
All these are with the patient's permission. You don't want to just go out and do it yourself. Our lady that we dealt with for so many calls for so long, we went through APS. We went through so many people trying to get her the assistance that she needed was just to have somebody to come by the house once or twice a day.
I've never really had a good experience with APS.
They're so inundated with all the calls and all the stuff that they're doing. It's hard for them to keep up, and unfortunately, that's just the way they are. It's their busy system,
and you may have to do a few things that you don't normally do. I have literally cleaned the feces off of a patient in his bed and remade his bed for him, and it was a weekend. Home health was not going to come out, So me, my partner, and our wonderful volunteer fire chief in one of our areas cleaned this man up, changed him with him griping at us the entire time, and remade his bed because I was not leaving him in feces for a weekend.
But ultimately, is that part of our job?
No.
No. But is it the right thing to do? And I think that's where our ethics what changes us from being just paramedics and just being somebody who runs the crazy calls and does all the crazy things. That's the part that I say when somebody comes up to me and says, man, I bet you've seen some crazy things. I'm like, yeah, I've changed a guy who could have been left all weekend with feces all over him. I took care of that person, and I made him a much better person for the weekend, made him more comfortable for the weekend. That to me is more important than the person who I've seen all kinds of crazy crud,
Yeah. I have my memories of my patients that were just, they were just great people.
Yeah.
Great people. And they weren't, these great calls that everybody wants. They were lift assists. They were, something like that. And I just, they were wonderful people. And once you get to know some of them and actually take the time to get to know them, because this is your area, it's amazing what you'll learn and who you'll get to know and the friends that you will make.
And not only that, but man, some of these people, they have stories that are just amazing. I mean, especially when it comes to, I love the geriatric population.
I've actually met a man who was ejected out of a fighter jet in the war.
But if you would have been like, all right, you just get in a truck, let's go to the hospital.
I would have never known that.
You never would have
Yeah.
known it. So you got to take the time to talk to these people.
Coolest thing ever.
Remember, our jobs are to be people as well.
Mhm.
And I think that's the key. This run review, as we kind of wind this down, the run review, the call was super awesome. And the medic who took care of it, she was flustered a little bit initially. She had
I think she thought that there was more she
on.
could have done, but there really wasn't. And I have to reiterate for her if she's listening is the patient needed dialysis. There was nothing you were going to do that was going to fix him.
Nothing in the back of that truck's going to fix
all you
it.
could have done was just start it, and you did.
Yep.
You did. You got him to where you needed to be.
Sometimes in a lot of our calls are just that, get them to where they need to be, the appropriate facility.
Mm-hmm.
And
because I guarantee they put in a PICC line or use sonogram to get that IV, something more than what we could have done in the back of that truck.
Oh yeah. And once they got that, they were able to get the dialysis done and get them taken care of. But ultimately we have to remember these calls are going to come, they're going to hit our plates. And when we get to these calls, we have to, realize when we get back to the station, we go back and look through and rewrite, and we write that report 100 times to make sure we got everything in it. That sometimes we're not going to fix everything.
Mm-hmm.
We're set, but in this situation, it ended up well because he ended up not in cardiac arrest. We treated him to our best ability to get him to the hospital. He got to the definitive care that he needed. And pretty much, that's a good call for me. You did a great job for, and I think one of the best things is this is another call that I think she's a 2-year paramedic.
2 or 3 year.
Yeah, 2 or 3 year paramedic who's making these decisions that when you haven't ever seen them before, those are the good ones. Unfortunately for us paramedics who've seen it for a long time, except for me, anytime I see the hyperkalemic patient, I run the other way because I always mess that one up. But ultimately, I think that's so it's important.
I can't believe you did that.
I know.
So my hyperkalemic patient.
You just Facebook.
Yeah, no, I've got something that I want to say, and for some reason my Facebook just went crazy. When I said that I had a hyperkalemic patient, it's something you'll never forget. There's calls that you'll never ever forget, right? And that's kind of like that blood sugar up on the wall thing. Brandy and I walked into, or we were called for elevated labs. 20-minute drive away. Go routine traffic. Pick this patient up. Take her to Metroplex. I think. Darnell, one of them. Anyway, we get there, and the mom's out there like, "Come on, hurry up!" And Brandy said, "I don't have a good feeling. While I grab everything, will you just go check on her?" And I walked in literally to watch this lady take her last breath. So 30-something years old. This was in a different area. So we then had to call 911 because now this is a 911 call. And we worked her, got her back, worked her, got her back, worked her, got her back. They took her, seven firefighters in the back of an ambulance. They worked her, got her back, worked her, got her back, took her to Metroplex. And she died. So we did inquire, what was this elevated lab? And it was hyperkalemia. So from that day forward, Brandy and I, that is, I can't speak for her, but I know her well enough to know that spoke to me. And I will never forget that. So when I see a peaked T wave, you've got my attention.
Yeah, for sure.
So I want to leave. So are we good?
Oh yeah. I think we're pretty much winding down here. Don't forget to go over to Whitestone Brewery. Try their Rated R. It will probably be a little different than this, but it is a very tasty beer. They have several others. And there's sometimes seasonal beers like the Melted Snowman, which I'm going to enjoy this weekend now that I've been told I can have access to them without having a podcast go on.
It's really good.
But yes, there's multiple good beers there. Whitestone Brewery in Cedar Park is awesome. Go check these guys out. They got really good brews.
Great atmosphere.
Yeah, it's super
Take
chill.
puppy.
Take your puppies.
So I want to leave you with something I think we've all heard at some point, and I think I'm making it a little less wordy than normal, but it's a little quote, and it's actually in my protocols. Yeah.
Really?
Yep. EMS does not save lives. God does. Our job is to entertain the patient until he makes up his mind. And that was by Dr. Red Duke. So keep that in mind. We're not the ones who fix this.
No,
things.
no. We ultimately we play the game. We make attempts, but we do not make the final call. Well, with that, I'm gonna finish my beer because it's super awesome.
Yeah, it's gonna make me sleep really good.
I'm gonna need you to finish that one up because the 10-point beer is something awesome.
I think I've drank more than you have, sir.
Yeah, well.
Is there still some in here? Oh no, thank God.
No, I've refilled mine and made sure I took the last bit of it. With that, guys, we're out of here. Look forward to some new stuff coming up. We've got some really big ideas coming up for the Whiny Medics coming up in January and stuff.
We have a few guest speakers.
We do. We have a few ideas with some guests that
As
we're going to
always,
discuss.
Put your input in our Facebook or our emails.
For sure. Go
I
ahead and
have a
like us
sticker.
on everything. Yes.
I have a sticker for Ashley Doran.
Mm-hmm. Oh, no. Fresh. The cop. Why for the cop?
Because she likes us.
Oh, my goodness. Can I put it on a wrapper of donuts?